Good afternoon and welcome, everybody. I'm Kim McGrail, and I'm a professor in the School of Population and Public Health in the Faculty of Medicine and Director of Research with UBC Health. Thank you for joining us today for this next session in the Health After 2020 dialogue series. Before we start, I'd like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to acknowledge that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you're joining us today from many places near and far. I acknowledge the traditional owners and caretakers of these lands. Today, I'm joining you from traditional, ancestral, and unceded territory of the Coast Salish people, the Squamish, Tsleil-Waututh, and Musqueam nations. So I'd like to make a few comments about UBC Health and the Health After 2020 program before introducing our speakers. So UBC Health works under the Office of the Vice President of Health, and we recognize the growing need for collaborations to address complex and interconnected problems facing society. We facilitate collaborations across disciplines, faculties, and campuses, as well as with partners and communities. Our work enables us to improve the ways we collectively train people, ways we develop knowledge, and shape policy. Our ultimate goal is to address inequities and improve systems that foster and support health. Through our initiatives, we aim to foster an active community of health research practice and mentorship. The UBC Health Dialogue series brings together scholars, students, and community partners to discuss important topics related to the health and well-being of society and to advance interdisciplinary knowledge translation. Our understanding of the determinants and experience of health and well-being has changed. In 2020, the COVID-19 pandemic accelerated some existing trends and put a spotlight on others, and we're now responding to the broad effects of that pandemic. We have the opportunity to learn from our collective experience and to think differently about how we define and value health, how we understand complex systems that produce health, and how we rise to the challenge of supporting equity and health across individuals, communities, and societies. In response to this opportunity, UBC Health developed the Health After 2020 program, which is designed to support researchers to engage in interdisciplinary collaborations and build a community of UBC Health scholars. Through the development of research collaborations, academic outputs, cross-campus conversations, and open dialogue sessions, the program convenes and informs people at this inflection point in our society. 8 interdisciplinary teams have been funded during this inaugural year to advance and disseminate their collaborative research, which includes leading a dialogue session. So today is the next session in the Health After 2020 dialogue series, and is titled Home-Based Virtual Reality Therapeutics for Mental Health Care, Opportunities and Challenges. Our panelists today are Dr. Tricia Chakrabarty, who's an assistant professor at UBC, and Dr. Elena Hernandez, who's a postdoctoral fellow, both from the Department of Psychiatry and the Faculty of Medicine. Also from the National Research Council Canada, we have Research Officer Nushi Chaudhry and Research Engineer Mark Huco. So please welcome Trish to start us off.
Hi there, thanks very much, Kim, and thank you everyone for joining today. We're very excited to be here. Yeah, so as Kim mentioned, we're going to be talking a bit about our collaborations work in developing virtual reality therapeutics for mental health. Specifically, our collaboration is working on depression. And as we go through, we'll explain a bit more about how our collaboration came about and what some of the aims of our collaboration are. These are our disclosures in terms of funding that has supported some of the work we'll be talking about. And these are the objectives we're hoping to touch on today in today's dialogue section. I'm going to start by giving a brief lay of the land in terms of current and potential emerging clinical applications for virtual reality technologies in the treatment of mental health disorders. And then we're going to discuss what some factors and processes might be that we can implement to improve the usability and efficacy of VR clinical applications. And for that, Nushi and Elena will be talking a little bit about the work that we've been doing for the specific program that we've been developing called bWell. And from there, we'll discuss how one of the next steps that really emerged from that work that we did was the importance of finding ways to implement VR so that they can be used at home for people. They can be used flexibly and in their own spaces to really improve the accessibility and scale up the potentials for this technology. So that was the focus of this Health After 2020 program and what we're hoping to sort of work on over the next year with the support of the Health After 2020 program. And so we'll describe what some of the challenges and opportunities are there and a little bit about what we're hoping to implement over the next year. So we just wanted to start with a few poll questions to get a sense of what people's experience and engagement with virtual reality is. So if you guys wouldn't mind taking a minute just to answer this first poll question regarding your personal experience with VR. All right, so it looks like, okay, that's good. So it looks like the majority have an interest in it, which I think explains why you're here today. But it looks like we have a good mix of some people who also have more personal experience with VR. And the second poll question, how aware are you of clinical applications using VR? So VR being used for like mental health or medical applications. Okay, so that's great. So it looks like the majority of people have at least some familiarity with VR in clinical settings. So that's good. Okay, so I mean, it sounds like probably most of you are aware, but I thought I would just start with a basic definition of what virtual reality is. So in general, virtual reality refers to a three-dimensional computer-generated interactive environment. And this environment can be created and delivered in immersive forms. So that could involve a head-mounted display, which is you see in that first picture on the top, which is probably what most of us think of when we think of VR. So that would be the headset and controllers. That could also be something called a cave setup, where you have the environment projected around you, like on multiple walls, the floor and the ceiling. And there are some non-immersive forms too, which you might recognize as sort of video game type setups. And then there are technologies called augmented or mixed reality, which merge virtual stimuli with real world environments. So if any of you have been furniture shopping recently, you might have been able to project an image, a 3D image of the piece of furniture you were looking at into your home. So that would be an example of augmented reality. Now, in the past decade, certainly VR in general has really been growing in popularity and accessibility. It's estimated that about a fifth of the US population will be using some form of VR and or augmented reality technology at least once per month in this past year. And as you can see from the screenshots here, these were screenshots from Amazon like last fall. You can go on Amazon and order yourself a top of the line HTC head controller set for $1,600, or you can get a $22 Google Cardboard set of VR glasses, and they'll be delivered to your door within a couple of days. So they're certainly growing in terms of their use and accessibility. VR use in healthcare specifically is also rapidly growing. It's already a multi-billion-dollar industry, and there are currently multiple applications that are in place. So that VR is being used for medical education, so teaching medical students or other health professionals about anatomy, helping them practice skills, helping them refine their patient encounters, and they are being used for therapeutics such as distraction. So I put a local to me example from PSYCHIATRY, where there is an ER doctor there who's implementing VR headsets to help with kids when they come into the emergency room to help manage anxiety and help distract them during potentially painful or uncomfortable procedures. It is also being used for pain management, such as chronic pain or phantom limb syndrome, and is being used for physical rehabilitation, for example, after a spinal cord injury or stroke. But what about VR in psychiatry or in mental health care specifically? To me at first, when I started learning about this, I don't think I would have thought that the applications for VR were necessarily very intuitive when it came to mental health care. But there was this review by Daniel Freeman, who does a lot of work in using VR to help with chronic psychotic symptoms. And he had this line that really resonated with me, where he said, difficulties interacting in the world are at the heart of mental health issues. Therefore, recovery concerns thinking, reacting, and behaving differently in these situations. And for me, that really clicked because it was like, of course, we have this technology where we can recreate real world situations that people can immerse themselves in and they can interact with. And they can do so in a lower stakes environment and a hopefully less anxiety provoking environment than the real world. So, VR could potentially have a huge role in helping people who have mental health issues or mental health concerns. And this is certainly playing out. So one application for VR therapeutics in mental health care that's really gaining traction is exposure therapy. So exposure therapy is kind of the cornerstone for treatment of most anxiety disorders, where you basically expose yourself to the feared stimuli in a gradual and progressive way. So with VR, it becomes really easy to potentially expose yourself to spiders, for example, if you have a spider phobia, engage with flight simulators if you have a fear of flying. But the applications are broader too, and they can help. VR could potentially help with things like exposure therapy for social anxiety or for PTSD. And one of the aspects of VR that we can really leverage is that we have complete control over the environment. And so the dose or the intensity of the exposure can be titrated really precisely and exactly the way we want it. So for example, if you had a fear of public speaking, or if you had social anxiety, and you were going to use a VR program to help with that, you can start off, with an audience like we have here on the left, and in the middle, which is kind of what you would hope an audience would always look like when you're speaking, like super engaged, maybe like even a little bit overly interested. And that might be a really good place for you to start working with that anxiety. And then as you get more inured to that and more comfortable, you can start practicing in front of audiences that maybe look quite disengaged or don't necessarily look that interested. So that's something that can be done with VR that can be really hard to replicate in real world settings. And there have been some really interesting studies where they've looked at the physiologic stress response that is elicited by these virtual environments. And they found that even though obviously people are consciously aware that this is a virtual environment, it's not real, the body reacts to it as if it is a real environment in terms of your cortisol levels, your blood pressure, other physiologic measures. So it does provide a real enough setting to actually experience the anxiety that can come with these feared settings, and to learn to manage and overcome them, which is truly the crux of exposure therapy. So exposure therapy, there is a fairly recent meta-analysis where they pulled together all the results from different types of exposure therapies using VR. And they did find that there was quite a large effect size supporting efficacy for VR exposure therapy across a range of different anxiety disorders. And they also found that, compared to traditional in-person real-world exposure therapy, they seem to have similar efficacy. However, VR can provide a lot of convenience in terms of recreating these real-world settings that can be difficult to replicate in real life. Although, as this will be a theme that will come up again and again, a lot of these studies are very small, and therefore the results are not necessarily precise or incredibly reliable, but it is certainly promising. So there are a number of other applications that are being explored in psychiatry that I won't get into too much detail, but just so you're aware, there are things like virtual reality cognitive therapy for people who have persistent delusions, so fixed false beliefs or paranoia. There's avatar therapy for people who have refractory or treatment-resistant auditory hallucinations, which allows the person to create an avatar that represents the entity that is the source of these auditory hallucinations and allows them over time to gain dominance and control over that avatar so it has less of an impact on their life. There's VR to help foster self-compassion skills where you create an avatar that represents yourself and you practice being compassionate towards that avatar. And VR is also being used to help develop mindfulness skills for a range of indications. Another application of VR in psychiatry that I'm going to spend a little bit more time talking about because it's relevant to our particular project is cognitive and functional remediation. So we know that psychiatric disorders, kind of across the board, are associated with psychosocial and occupational dysfunction. And treating the core symptoms of whatever it is, a psychotic disorder, mood disorder, anxiety disorder, is obviously hugely important, but it doesn't always guarantee that you're going to have full functional recovery, that this person is now going to be able to function and interact in the real world in the way that they would like, even though their symptoms are better. One important mediator of this psychosocial or functional impairment is cognitive deficit, so problems with memory, attention, concentration, executive functioning. And there have been remediation programs that have been specifically designed to either help people practice real-world skills, so that would be functional remediation, or help them with cognitive deficit areas. So that would usually involve drill and practice type games where you're doing, for example, like memory games or attention games that get progressively more difficult. These types of programs do show evidence for efficacy across a range of psychiatric disorders, particularly mood and psychotic disorders. But there's sort of inconsistent evidence in terms of how well those skills that are practiced and developed in these programs then transfer to the real world. So that's where there's maybe a huge opportunity for virtual reality, because we could potentially create a very immersive, naturalistic setting to practice these skills and thereby help improve this real world transfer of skills. So we did a systematic review of VR studies that were examining virtual reality cognitive remediation across all psychiatric disorders. And we found, there were 13 studies, so not a huge number. The majority of looking at people with primary psychotic disorders or mostly schizophrenia, a few that looked at substance use, and one that looked at depression. And just to give you a sense of what these types of interventions look like, so generally there's somewhere between 8 to 20 sessions total, usually half hour to 1.5 hours per session, and usually weekly or a few times a week. And they can range from things like, again, those drill and practice type games. So this is an example of a screenshot from one program where you go through a field and you have to pick flowers that have a certain characteristic while ignoring all of the other types of flowers, and you have to try to do it as quickly as you can. There's social cognitive or social skills training, so examples where you might be in a virtual conversation or job interview, for example. Real world simulations to help you practice real life skills, the most common being grocery shopping, so having a grocery list and having to navigate the grocery store and pay for all your purchases appropriately. And then vocational training, so helping people with, learn to work in retail environments or as cashiers or so forth. All of the studies that we found reported improved cognitive functioning in at least one cognitive domain. And the studies that included a comparison with traditional therapist-led cognitive or functional remediation found that both the VR and the traditional interventions were equivalent in terms of the degree of improvement. And in the studies that actually looked at this, there were improvements in real-world social and vocational functioning, and it was the interventions were fairly well tolerated. There were dropout ranges up to 20%, which is fairly good. There were definitely some limitations, though, in that not all studies looked at real-world functioning very consistently, and few studies assessed long-term changes. And again, the studies were generally small. And it still remains unclear what the frequency or intensity of sessions is optimally, and what is the added value of the immersive, having like the headset, for example, versus doing these things in the computer. That wasn't really well examined. So certainly a lot of limitations in literature, but promising in terms of first steps. So where we are now in terms of using VR in psychiatry, again, a lot of promise, but a lot of limitations. So as I mentioned, a lot of the studies, majority of the studies, have really small sample size, or they may lack control conditions to compare the intervention to, or they use different types of control conditions, which are more or less optimal. And there's really variable and biased reporting of results. And then there's pragmatic limitations in terms of if we do decide to really scale up and use VR in a very systematic way for mental health care, what about the affordability and accessibility of equipment? For people who perhaps are not as technologically savvy as the undergrads we have going to UBC, how do we help bridge that divide for them? And how do we optimally integrate this into clinical care? Like, do we envision these interventions more as standalone interventions that people do on their own, or do we complement it with real-world clinical care? And then what are some more foundational limitations? So how do we ensure that these interventions are not just technologically cool and shiny and exciting, but actually have some theory-driven, real, solid psychological approaches and neurobiological basis for what they're doing? And how do we ensure an optimal user experience? So we do have this virtual reality consensus report that was put together by VR experts to address this very issue in terms of how do we develop usable and efficacious VR applications for clinical, not just mental health, but clinical use in general. They describe the current state of clinical VR research as the Wild West, again, often focused more on tech rather than the theories behind it. And they found that it was vital to include both patient and clinician, provider, end users early and often, right from the development of VR treatments. So they proposed a three-tier approach where you start with the content development, which will be very collaborative with end users, both clinicians and patients, where you develop the content of the program. Then you do pilot testing of feasibility, acceptability, and tolerability. And once you've established that, then you go on to the large-scale RCTs that evaluate the clinically relevant outcomes. So that sort of approach would, address a lot of the limitations that I mentioned before in terms of making sure that we're developing something from the outset that's theory driven and going to end up being useful to patients because we get their voice in from the beginning, that we can really use that VR2 stage to optimize the usability and the user experience. And then we have a really large, well-designed RCTs to ensure that the intervention is actually efficacious. So this leads me to our specific program that we're working with. So just like with other psychiatric disorders, depression or major depressive disorder is associated with a myriad of cognitive deficits that are associated with difficulties in psychosocial functioning in depression. And importantly, even though treating symptoms will help, certainly, the cognitive deficits may not completely go away even when the person is no longer feeling depressed. They can still remain detectable. So we do need treatments that specifically target cognitive functioning in depression to ensure that these people achieve full functional recovery, but we have very few treatments that specifically target that. So with that, I will pass it off to Nushi, who will talk about this program that we are developing for depression.
Thank you, Trisha. You can go ahead to the next slide, please. So, hello, everyone. It's a pleasure to be here today and to be provided with the opportunity to touch on the development of the bWell platform. So we are a group of researchers at the National Research Council Canada, which have diverse backgrounds in biomedical engineering, neuroscience, and software development, where over the last few years, we've been developing an immersive and interactive cognitive care platform called bWell. And Trisha, if we could go to the next slide, please. Thank you. And so bWell, it delivers tasks as a multisensorial experience where we're targeting general aspects of cognition common to many disorders, including mental health. And notably, what we have in place is a cognitive care network, which are 5-year collaborations where we're evaluating the use of bWell, and one of which is one that we have with UBC, for which we're very happy to have the opportunity to present to you today and go into a bit more detail. So since not everyone may have had the opportunity to try immersive virtual reality, I wanted to start by highlighting its affordances, which Trisha just very nicely described, and I thought to go just a little bit more in detail. So this is a technology that aims to completely immerse the user and giving the impression that one has stepped inside of a synthetic world when they put on a headset. So because of this affordance, immersive VR has the capability of eliciting genuine responses in a user as they interact in this virtual world. And as well, it affords as well multisensory stimulation. So as the user interacts, there are visual, audio, haptic, which are cues, and having this type of multisensory stimulation aligns very much so with how we function in the real world. As well, we can create complex environments while still controlling the input to the user. So complex environments, but where we have now an experimental paradigm with tight experimental control at the same time. And it's also quantitative. So every stimulus, cue, action in VR can be recorded and analyzed either live or offline via post-processing. And what's very nice is that we have the benefit of being able to repeatedly carry out the same task. So when you can have this repeat practice of skills or strategy, this is what really helps to promote long-term improvement in deficit areas. So bWell has been designed as to serve as a broadly applicable toolkit. But we're targeting general aspects of cognition that are commonly impacted across many disorders or in daily functioning. And there are 8 exercises that target different domains, for example, attention, working memory, or the ability to multitask. And what's nice about VR is that we have the freedom to create any synthetic environment in order to match the needs of the target application. And that's what we've been doing as part of our collaboration with UBC, where we're creating new environments for the core exercises as a part of the bWell D program, which is where we're using bWell exercises to target cognitive remediation for major depressive disorders. In terms of the development of this platform, what we've used is agile development. So this is a process where what we have in place are early adopter groups where we can iteratively deliver advances in development to end users who can provide us with domain-specific perspectives, feedback, input that guide the next iteration of development. And for this, we use technology readiness levels, and this is a framework that we use to integrate and structure the stages of clinical input according to the maturity level of the technology, where it has advanced in terms of its development, which is what you can see in the figure. We've also developed bWell to be multimodal and multi-platform in that it supports a variety of hardware, which is very important these days because there are many headsets that are available on the market. And we've also put out a challenge for multimodal sensing, where we could have the simultaneous capture of EEG and physiological measures of users while they're trialing VR. And this is currently being taken on by Canadian companies, Maya and Interaxon. Our early development activities were really to demonstrate the proof of concept and really looking at safety and its use with studies that were conducted in our lab with healthy participants. And what we really aimed to do here was to generate the evidence required to support testing in clinical populations. And if you're more interested, in having more details about this work, I've listed a couple of articles that we have on the topic, and we'd be happy to send anyone who requests these articles. Our mid-TRL activities, which are once we've established the proof of concept, was then to take bWell out of the lab and into clinical settings. And this is where we are following the guidelines that Tricia just described from the VR core framework, which are guidelines for developing VR therapy for its development and validation. And what we're doing is following these guidelines with all of our collaborations, where bWell, its core exercises are being customized for a variety of clinical populations. With our strategy of focusing on cognitive domains rather than a particular disorder, what we saw was that bWell appealed to different types of treatment providers, and which led for us to establish the Cognitive Care Network. And with this network across Canada, what we're focusing on is its iterative development with input from the experts, and as well looking specifically at its therapeutic use. So currently we have 5 sites as part of this network across Canada, as well as 1 in Japan, for a variety of applications in clinical populations. And each of these have a 5-year collaboration in place to give us the time required to gather the evidence needed to support its use as a digital therapeutic. And at this point, I'd like to invite Elena to present our work together for bWell content development and integration of feedback from end users, where we're targeting cognitive remediation for major depressive disorders. Thank you.
Thanks, Nushi. Everyone, I'm Elena. Just let me tell you about the qualitative research we conducted about bWell. We call this step a co-design of bWell with end users, specifically with healthcare providers and patients with depression. And as it has been mentioned before, the importance of including this end user involvement is that it is an integral part of the design of any digital intervention process according to best practice and the most recent guidelines on this topic. Since it has been shown that lack of end-user involvement is one of the factors that explain failures on digital interventions. So therefore, the main aim of this qualitative study was to obtain patients' and clinicians' perspective and thoughts about bWell. This has been mentioned before, VR cognitive remediation intervention for depression specifically. And with this feedback, we also aim to identify what can be improved in bWell to make it more enjoyable and, of course, more feasible for treating cognitive symptoms of depression. And here's how we did it. We conducted remote interviews through Zoom with health allied professionals and people with depression. We recruited participants online, and in the case of patients, they were pre-screened by phone to ensure that they met the inclusion criteria for our study. The interviews were then recorded and transcribed, and they were analyzed through thematic analysis. And this is a qualitative method that identifies recurring topics or themes that are mentioned often by participants. So it's a form of summarizing large amounts of information in a more condensed and structured way. And what did we ask the participants in the interviews? Firstly, they answered a short Qualtrics questionnaire about some demographic data. And patients additionally responded to a battery of psychological/psychiatric measures. Practitioners answered some questions about their clinical practice as well. And then I proceeded to conduct a semi-structured interview about participants' experience with VR, both for recreational and clinical applications, and their opinions about a cognitive remediation treatment for depression through virtual reality. And finally, I show them pre-recorded video samples of bWell in order to obtain their feedback about it so we could improve it as much as possible. We show them 4 different tasks, the ones that are displayed here in the pictures. So each of these tasks aim to train a specific cognitive domain. And yeah, these are the results. We interviewed 15 patients and 12 clinicians. Patients have between 21 and 63 years of age, so it was a nice range of ages with a median age of 31 years old. Most of them had a diagnosis of major depression disorder. We had a patient with dysthymia, one with bipolar disorder. We had a few participants who stated that they were diagnosed with depression, but they didn't quite remember the specifics of the diagnosis. And we had one person who was undiagnosed, but after reviewing the screening responses that he provided, we deemed him eligible to continue with the process. Patients have between 3 and 16 years since their diagnosis. And all of them were above average in all the clinical measures that they answered. And they also all reported having an affectation in their jaws because of their depression. And psychiatry, we had the clinicians were psychiatrists mostly. About half of the sample were psychiatrists. We had a couple of occupational therapists, a psychologist, a clinical counselor, and a neuropsychologist. They had a median of 17.5 years of experience as mental health practitioners. Most of them work in outpatient settings, and only 5 clinicians had hands-on experience with cognitive remediation, although all of them were aware of the existence of this sort of intervention. And what about the thematic analysis? We identified 5 underlying themes in the interview data. These themes overlap between clinicians and patients, meaning that the information they provided was quite similar. The themes were related to the preconceptions participants held about bWell and VR, the potentials they saw in this sort of technology, the advantages of a virtual environment, the realism that a virtual reality intervention can offer, and the need of a customizable VR treatment. For the first theme that we identified as hopefulness and optimism, it reflects how all participants were familiar with VR, either having themselves hands-on experience with it or having seen it used by someone else for either recreational or clinical purposes. The great majority of the participants have this why not sort of attitude towards VR for depression. They were optimistic towards it and were willing to know more about it and try it. This is an exemplifying quote. I don't really know too much about it, but I'm very open to learning more. I guess I don't know enough to say whether I see potential or not, so I'm eager to learn more. The second theme relates to how, despite this familiarity with virtual reality, participants sort of struggle to see how virtual reality or a cognitive remediation intervention could help improve depression specifically. They mention things like this quote, I don't see the application to depression or bipolar disorder. So, in that end, those are the 2 disorders I treat the most. So therefore, I'm not particularly looking at this, and I'm surprised to hear about a virtual reality treatment for depression. However, once we provided the rationale on how cognitive remediation treatment could help for depression and how VR could be an advantageous means to deliver this sort of treatment, they all said it makes sense, and were optimistic and intrigued about it. The third theme involved all the advantages that a VR treatment can involve and its virtues as a digital intervention. According to their own personal experience, and especially after watching the video samples of bWell, participants consider it a fun alternative to conventional depression treatments. They also consider it convenient because of the portability of VR. It allows them to engage in a treatment in a more independent way, mentioning that they would like to do it at home. They mention things like the quote right here. It seems like a nice way to do it yourself in your own time, in a quiet environment and not have to go anywhere. This type of comment was particularly common because of the pandemic. People seem to prefer to stay home if they don't have to go out. So yeah, the pandemic made participants much more wary of going out. The fourth theme is about the reality that virtual reality can offer. Someone mentioned that VR is the second best thing to real life. They mentioned things like the quote here. It's remarkable, the sense of presence when you're in the VR environment. Unless you've experienced it, it's hard to imagine, it's very much like being in the real world. People mentioned wanting the virtual environments to look similar to where they work, or that they involve objects that you will use in your day-to-day life. And because of the versatility of VR, this is something that is attainable. The possibilities are endless, and of course, within the limits of the technology, but it allows you for a very large variety of settings that can be very realistic. And the last theme involves comments participants made about the necessity of having a customizable VR treatment. Participants mentioned how things like the severity of their symptoms, the presence of other comorbidities, and their own personal preferences could have an effect in their use of VR treatment. And therefore, their individual needs should be accommodated when getting involved in a treatment of this nature. They mentioned things like this quote right here. I think when you're depressed, it'd be really hard if there's any sort of resistance in that process. I think a really anxious person or a really depressed person will be like, nope, I can't deal with it. It's not working, I'm done with it. Not going to use it today sort of mentality. And in regards of specific comments made about how bWell can be improved, the most frequent comment was a preference for doing the treatment at their own home. Participants also mentioned they like that the VR environments depicted realistic settings and involved realistic objects and interactions. They mentioned wanting to do more than just looking around with the headset, so having multisensorial stimuli, having auditory cues and distractions, also utilizing their hands to perform actions and interact with the environment. And they also mentioned wanting the bWell task to be sufficiently challenging so they didn't eventually become too trivial or too boring. So according to this feedback, we modified bWell. I would like to briefly show you an example of how the tasks look before the end user feedback. The one that is playing is the egg task, which targeted sustained attention. In this task, participants are asked to look around and look for eggs in that office. And once they find the egg, they have to fix their gaze on it until they make it hatch. Okay. So this task was one of the tasks that received the most feedback from the participants. They considered it a bit dull with nothing much going on. So in the next video that I think is playing right now, it displays some of the changes we made to the program. There are some animations, some people wandering around, some fake eggs, just to add more challenge to it. Some humanoid avatars there. And Trisha, if you can play the next video. Okay, this next video depicts a harder version of the task, where participants have to stare at the eggs for longer. There are some audio distractors as well, which are fairly frequent. I'm not sure if you can hear the audio. Is the audio playing? The audio should show some chattering, people talking, phone ringings, and fake eggs as well. So yeah, these are some of the changes we made to the task, and of course we made more changes to it, but for the sake of time, I just show you this brief example. And in conclusion, for this step of the research with bWell, participants, both patients and clinicians, consider bWell an interesting and fun alternative to treat depression and its cognitive symptoms. They also believe this is a potentially feasible intervention. They provided very useful suggestions to improve the program, so we encourage future VR interventions to do this as well in order to improve the treatment and potentially enhance patients' adherence and engagement in the treatment. And we also recommend re-interviewing participants to show them the changes made to the program, so it can be ensured that these changes made to the program are on the right track and satisfying this end user feedback. So yeah, that's it on my end. Trisha, do you want to continue?
Yeah, thank you very much. Yushi and Elena. The auditory distractors actually startled me in that last video, so I think they should be effective. So so Elena's work really highlighted to us that, there's a lot of changes we could make to the program itself that would improve the efficacy and the enjoyability and feasibility. But one of the things that kept coming up, as she nicely outlined, was this desire to have it available to use, the program to use at home. So if I could just ask if you could answer this poll question. If a healthcare practitioner asked you or recommended to you that you use a certain VR application to improve whatever aspect of your healthcare, what would you say, in your point of view, what would be the main barrier? Okay, so it looks like it's 50-50 between cost of equipment and need to travel to a specialized clinical site, which I think is kind of what we found as well. So this led us to this question that we're hoping to address. So, over the term of this Health After 2020 project is, how can we adapt bWell to be given at home, and what sort of protocols can we develop for that? And hopefully the hope is that these types of protocols can then be adapted and used for a myriad of VR clinical programs. So when we were looking into it, there have certainly been some small studies that have looked at home-based VR for clinical applications. So there have been some studies looking at it to promote lower limb rehabilitation after spinal cord injury, or to help with chronic pain management. In terms of specific for mental health, there has been one study, a pilot study, looking at using an immersive home-based social training to help with social anxiety, which showed some promising results. And perhaps most relevant to our current state, there was one study that was done in Italy, and actually with Italian citizens who had been in strict lockdown for at least a couple of months right at the beginning of the pandemic, where they designed this program, this VR program, that could either be done immersively or non-immersively, to see if it could help with pandemic-related stress and distress. And it was a combination of this really relaxing environment as well as a series of VR exercises. And they found that after a 7-day intervention, it did result in decreased depression and stress and a sense of increased social connectedness, which kind of emphasizes the potential use of VR in this sort of post-pandemic lockdown world that we're in. So there's certainly a lot of promise for home-based VR applications, but there's a lot of considerations too in terms of how do we recruit patients, especially those who aren't particularly comfortable with VR or VR technology. How do we adequately set them up at home and train them on the equipment? How do we ensure adherence and monitor that they're using the programs adequately and appropriately? And how do we do clinical assessments to actually monitor their progress? So Mark is going to talk a bit about some of the models that we're thinking of and how we're thinking of potentially working around some of these issues.
Okay. Thank you, Tricia. Here, so presenting on the opportunities which VR-based digital therapeutic can provide, such as increased accessibility and scalability of treatment capacity, while also addressing concerns around privacy and security. For context, for a traditional in-person VR treatment, the patient receives an initial assessment in the clinic. The clinician configures their custom VR exercise plan and pre-schedules appointments with the users to attend sessions in the clinic. After which, data and records remain within the clinic, and the clinician can review the metrics of the patient's performance during their visit and make adjustments. So VR therapy has the advantage of enabling what we call asynchronous care delivery. So the graph on the right shows as we move from a typical in-person care to asynchronous care, scalability of the health delivery increases, but we also need to take additional assurance that engagement, safety, and evidence of outcomes remains valid. What we're proposing actually is a hybrid VR model where the user performs VR exercises at home on their schedule without the need to travel to the clinical site. During the exercises, the user receives objective feedback during the session. The user's performance data is shared with the clinician, enabling remote monitoring. In-person visits are needed less frequently, and the time during them is focused on problem solving rather than on reporting. For VR use in the home with remote monitoring, once again, the initial assessment occurs in the clinic, and the VR headset is provided to the patient. The clinician selects and assigns the exercise plan in the clinical dashboard, and this is performed on the upload in area 2. In their home, the user performs their session while receiving feedback from the system as number 3. And the session data is uploaded and processed in the cloud when metrics are sent to the clinician dashboard in cross 4 and 5. In the clinician dashboard, this allows for the patient to be monitored with progress being reviewed and exercise plans being modified. Here, for contrast, the synchronous model is a series of in-person visits for treatment, whereas the hybrid VR model, the patient performs exercises at their home asynchronously between clinical appointments. The clinical appointments can now focus on problem solving and progression. And the hybrid model improves treatment capacity in the healthcare system and provides patients with improved accessibility and reduced barriers to access. Here, the VR hybrid approach has technological challenges. For the user, we want to minimize the technology complexity. So we're looking at selecting a standalone headset. So there'll be no laptop, no cables, just a headset they can use. For the clinic, which could have tens of headsets, we want to minimize the workload by using a centralized headset management process that sits behind the software. And for the patients, when they're actually using the VR headset interaction in the home, we want a simple, minimal interface for acceptable to non-technical users with tutorials for familiarization training, uncomplicated exercise workflows, easy to interpret feedback during the exercises, and seamless usage from start, being able to pause exercises to continue on later. And in the clinic, the clinician dashboard would be via web portal for secure remote monitoring and user exercise management. Here, in a cross implementation, there will be a focus on privacy and security, from controlling the data during collection, transmission, and storage, and also selection of VR hardware and peripherals with privacy policies suitable for the application and for use in this area. And for this, we're obtaining guidance from NRC's privacy offices to assist us in making these choices. Now I'll turn this back over to Tricia.
Yeah, thank you, Mark. So just in conclusion, we know that VR has therapeutic potential, although we do need further large-scale studies, and we need multidisciplinary participatory research designs in order to create feasible and effective interventions, and that home-based use can substantially improve accessibility and feasibility, and that's our hope to really develop and work on over the next year.
So I'll just start by saying thank you. That was absolutely fascinating and so comprehensive in what you presented. So thank you to all of you for that. I'm going to pose a question to you. This comes from knowing a little bit about your interest in equity, and I'm just wondering how you're thinking about equity. So you talked a little bit about the, accessibility of digital. So that's one consideration. But what about language or age as other considerations for adaptability and usability of this kind of technology?
Yeah, so that's a great question. So we haven't really looked at, Nushi and Mark can correct me, but I think at this time we only have an English language version, although maybe there's a French language version as well. But that's certainly something that we'd be looking at in the future. In terms of age, it's a really interesting question because we've actually found in a lot of the preliminary work that we've done that people who are like 60 and above don't seem to find bWell any less enjoyable or engaging than people who are younger. So there doesn't seem to be the type of age divide that we maybe would have expected in terms of how much they like using the program. In terms of if they were to use it on their own and at home, there would definitely need to be consideration around supports to help with setup and maintenance, perhaps for older people compared to younger people. So that's something we're definitely looking at in terms of like our protocols to ensure that those adequate supports are there if we're going to home-based use.
Yeah, so maybe another indication how we underestimate certain groups and make assumptions that we shouldn't make about the desirousness of some of the stuff. So I just want to thank you again. What a wonderful, terrific contribution to this Health After 2020 dialogue session. And it really did provide such a comprehensive view of what you're doing and such a great program. So thank you for all of that. I also want to make sure that everybody is aware of some upcoming sessions in the dialogue series. So we have another on Wednesday, April 27. This is going to be looking at barriers and facilitators to health equity. around opioid prescribing for pain conditions. That's going to be led by Dr. Rita McCracken and her colleagues. And then on Wednesday, May 11, we have a session on engaging patients before and after childbirth. And this it has a specific from all walks of life. And that is going to be led by Dr. Marianne Bidler and her colleagues. I'd also encourage you to sign up for the UBC Health newsletter so you're aware of other events and opportunities. So thank you again to our speakers and to all of you for joining this session.